Good morning and welcome to day 2 of this public meeting of the Physician-Focused Payment Model Technical Advisory Committee known as PTAC. I'm Lauran Hardin, Vice Chair of PTAC. Yesterday we began our day with opening remarks from the CMS Administrator, Chiquita Brooks-LaSure, and she offered some context on how our work fits into her vision. Today, we're honored to be joined by Dr. Liz Fowler, the Deputy Administrator of the Centers for Medicare and Medicaid Services and Director of the Center for Medicare and Medicaid Innovation. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President of Global Health Policy at Johnson & Johnson. She was Special Assistant to President Obama on Healthcare and Economic Policy at the National Economic Council. From 2008 to 2010, she served as Chief Health Counsel to the Senate Finance Committee, where she played a critical role in developing the Senate version of the Affordable Care Act. Welcome, Liz.
Thank you so much, and good morning, everyone. And it is definitely morning here in California, where I'm traveling for meetings and site visits, so I'm sorry I'm not there in person. I'm really pleased to be able to join you for PTAC's quarterly public meeting, and I want to personally thank PTAC Chair Dr. Paul Cassell and Bruce Steinwald for their contribution and professional dedication as 3-term committee members. Thank you so much for your service. As Lauran said, CMS Administrator Chiquita Brooks-LaSure shared the CMS strategy yesterday and how value-based care supports her priorities related to equity and innovation. As with previous PTAC meetings, your agenda this fall is extremely relevant to the CMS strategy and the administrator's priorities related to value-based care. And in particular, population-based total cost of care models are central to the CMMI strategy. The June presentations and discussions and the presentations yesterday and the ones you've planned for today will help inform our pipeline of models. And I want to commend PTAC for including a mix of policy experts, state policy perspectives, practitioners, and payers. These are exactly the perspectives that help inform our work. In my time here today, I'll spend a few minutes highlighting some of our most recent work and preview what's coming next. As PTAC is well aware, the CMS Innovation Center is committed to pursuing new care delivery and payment innovation models. And in doing so, we're thinking about how these models can inform future Medicare and Medicaid policy to improve these programs for beneficiaries today and into the future. In addition to our care delivery and payment innovation models, we're focused on increasing data transparency for better insight into model performance, incorporating social determinants of health, screening and referrals into models, collecting health equity data, and we also have ongoing initiatives focused on risk adjustment and improving our approach to setting payment benchmarks. We anticipate engaging with stakeholders, including PTAC, on new models and cross-cutting initiatives as they're developed. This summer, the CMS team focused on specialty care models, led by Sarah Fowler, published a blog that described how Innovation Center model tests have demonstrated improvements in lowering expenditures and enhancing quality for specialty care. Episode-based payment models like the Bundle Payments for Care Improvement, or BIPC model, and the BPCI Advanced model, as well as the Comprehensive Care for Joint Replacement, or CJR model, focused on specialties that provide an important foundation for increasing access to coordinate and integrate specialty care. We are using these lessons learned to inform a comprehensive specialty care strategy, which we hope to announce later this fall. And based on a request for applications received earlier this year to solicit participants for the ACO REACH model, we recently announced a list of provisionally accepted organizations who could participate beginning in January 1st, 2023. ACO REACH is a redesign of the global and professional direct contracting model. It's intended to better align with CMS's commitment to advancing health equity and in response to stakeholder feedback and participant experience. We're excited about the factors that incorporate into this model that are intended to advance health equity, including a new health equity benchmark adjustment and requirements for organizations to develop and implement a health equity plan. This past summer, the Innovation Center also announced a new voluntary enhanced oncology model, or EOM. The model will test how to best place cancer patients at the center of their care team that provides high-value, equitable, evidence-based care and improves care coordination, quality, and health outcomes for patients. This model also holds oncology practices accountable for total cost of care to make cancer more affordable and accessible for beneficiaries. And the model will require practices to screen for health-related social needs. We're including many lessons learned from the oncology care model, as well as feedback from stakeholders in this new model. It's a 5-year model, and it will launch on July 1st next year. And finally, this past August, the Innovation Center made good on our promise to improve data sharing by making available new research identifiable files, or RIFs, for 6 CMS Innovation Center models: the Global and Professional Direct Contracting model, the Oncology Care model, the BPCI Advanced model, Comprehensive Primary Care Plus, or CPC Plus model, Kidney Care Choices model, and the Primary Care First model. CMMI continues to build on the foundation of innovation for innovation in healthcare, and we believe success should be measured by how well it improves health experience and affordability of care, and how it supports partnerships between patients and providers and stakeholders across the system to drive transformation. As we're driving accountable care, we're incorporating beneficiary perspectives into life cycle of our models, implementing more patient-reported outcome measures to measure what matters to beneficiaries, and focusing on evaluating beneficiary experience in models to ensure that our models are accomplishing their goals. In fact, later this afternoon, we're hosting a webinar focused on our strategy to incorporate patient perspectives into models. If you're interested, I'm sure it's not too late to sign up. Let me close by thanking PTAC for this opportunity to share what the CMS Innovation Center has been working on and where we're heading. And again, to send my thanks and best wishes to Dr. Sale and Bruce Steinwald for their commitment to PTAC and its mission. I hope the second day of your meeting is just as productive as it was yesterday.
Thank you so much for providing those remarks virtually, Liz. It's really exciting to hear all the developments, and we were looking forward to working with you and your team over the next year. Yesterday, we heard from several guest presenters on their vision for how population-based payment models can help us move forward toward a more proactive, patient-centered healthcare system. Today, we have 2 more listening sessions of experts ready to share their thoughts on payment considerations and financial incentives for total cost of care models. We've worked hard to include a variety of perspectives throughout the 2-day meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. We'll then have a public comment period. Public comments will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. Finally, the committee will conclude the day by shaping our comments for the report to the Secretary of HHS that we will issue on this topic. Because we might have some folks who weren't able to join yesterday, I'd like the committee members to please introduce themselves. Share your name and your organization. And if you would like, you can share a brief word about experience you may have had with population-based payment or total cost of care models. I will cue each of you. I'll start. I'm Lauran Hardin, Vice President and Senior Advisor for National Healthcare and Housing Advisors, and have led value-based payment model implementation in multiple settings across the country. Larry.
Good morning. I'm Larry Kaczynski. I am a gastroenterologist and have been involved in value-based care for the last decade. I'm currently the Chief Medical Officer of Sonar MD, a company that was formed on the heels of our presentation to PTAC back in 2017. We were the first PTAC recommended physician-focused payment model, and it spurred the formation of Sonar MD, which is involved in value-based care for patients with complex chronic diseases.
Good morning. I'm Dr. Jennifer Weiler. I'm the Chief Quality Officer at UC Health and co-founder of our Systems Care Innovation Center and Professor of Emergency Medicine. And I helped co-develop an alternative payment model for acute unscheduled care.
Good morning. I'm Josh Lau, a physician and faculty member at the University of Washington, where I'm fortunate to help lead value-based payment and care redesign in our system, as well as contribute to evaluation and research on these topics.
Good morning. Angelo Sinopoli, a pulmonary critical care physician by training, presently the Chief Network Officer for Upstream, which is a value-based risk-bearing organization. Prior to that was the Chief Clinical Officer for Prisma Health, where I also developed a large clinically integrated network that was involved in downside risk and founded and developed the Care Coordination Institute, which was an enablement company for organizations going into risk arrangements.
Good morning. I'm Walter Lynn, founder of Generation Clinical Partners, also a member of the Public Policy Committee at the Society for Post-Acute and Long-Term Care. Our medical practice cares for Medicare beneficiaries residing in senior living, especially nursing homes and assisted living facilities.
Hi, I'm Dr. Chini Puluru. I'm a family medicine physician by trade. I lead clinical operations as vice president for Walmart Health and Wellness, where all of the things that touch clinical delivery and clinicians are under my umbrella. I also lead their value-based care strategy. Prior to that, I was at DuPage Medical Group, now called Dewey, where I led the clinical care delivery platform as well as value-based care.
Good morning, Lee Mills. I'm a family physician. I'm Senior Vice President and Chief Medical Officer at Community Care of Oklahoma, which is a regional provider-owned health plan operating in Medicare Advantage, individual exchange, and commercial space, primarily on a total cost of care capitation payment model. Prior experience includes helping lead 2 different MSSP plans in 2 states, and then operating and leading 4 different CMMI models over the last 15 years.
I'm Bruce Steinwald. I'm a health economist right here in Washington, D.C.
Paul Casal, a cardiologist. I lead population health at New York Presbyterian and lead the ACO for Columbia University, Weill Cornell Medicine, and New York Presbyterian.
And Jay is joining us virtually. Jay, please go ahead.
Good morning, everyone. My name is Jay Feldstein. I'm an emergency medicine physician by training, and currently I'm the president and chief operating officer of Philadelphia College of Osteopathic Medicine. And prior to this role, I spent 15 years in the health insurance industry in various roles in both commercial and government programs.
Thank you, Jay. So next, I'm excited to welcome the experts for our 3rd listening session for this 2-day meeting. We've invited 4 outside experts to present on financial incentives, specialty integration, and performance metrics in population-based models. You can find their full biographies on the ASPE PTAC website. Their slides will be posted there after the public meeting as well. After all 4 have presented, our committee members will have plenty of time to ask questions. Presenting first, we have Dr. Amol Navathe, who is the co-director at the Healthcare Transformation Institute, director at Payment Insights Team, and associate director at the Center for Health Incentives and Behavioral Health Economics at the University of Pennsylvania. Welcome, and please begin, Amol.
Good morning. Thank you so much for the invitation to come join and present on financial incentives and performance metrics related to primary care and specialty integration. If we can go to the next slide, please. Are we able to advance to the next slide? Thank you. So I will be discussing focused around this notion of how do we marry population-based versus specialty-based model approaches, particularly given that both have been important to have been tested in the past decade plus post the Affordable Care Act. In fact, both of them have a history of being tested well before that, going back to the early 1990s. In general, if we think a little bit about what population-based models have produced for us, certainly relative to not using population-based models in this case, we've seen gains in quality, so quality improvements, specifically focused around reductions in hospitalizations and other acute care. We've seen some increases in efficiency in post-acute care use as well. And we've seen overall that there's been a decrease in the total cost of care, as well as specifically around Medicare spending in models that the Medicare program has tested. On the other side of the page, if you will, we have specialty-based models, which are heavily focused around specialist physicians and hospitals and other institutions that take care of patients who are largely being cared for because of their specific conditions. There, the goals have been, and I think to some extent the results have been, to reduce cost and variability in practice patterns and cost. A lot of that effort has been focused around institutional post-acute care, such as skilled nursing facility use, inpatient rehab facility use, as well as home health use. And we have seen some early successes, certainly in that space. We've also seen some quality improvements focused largely in the context of utilization again, so thinking about readmissions, for example. Some advantages of specialty-based models is that they're by definition more focused than a population-based approach, and to some extent they're more practical for hospitals and physician organizations, as well as other organizations such as post-acute care providers in coordinating. Another advantage I would highlight relative to population-based models is that there are more options for policymakers to incentivize participation, here chiefly meaning that specialty-based models have been tested in a mandatory fashion with the Comprehensive Care for Joint Replacement Program, or CJR program, that the CMS Innovation Center had put out and is currently running as well as voluntary programs. And relative, for example, population-based models, which have been much harder for a variety of reasons to try to mandate participation in. Next slide, please. There's understandably a number of different policy questions around value-based payments, alternative payment models. I outline here several. So one chief example would be the impact on cost and quality relative to not having those models. We're also very interested in where those savings may be located. In other words, who's generating those savings and from what type of practice pattern change. There's been some concerns more in the case of specialty-focused models or episode-based models around whether there may be some sort of volume response from clinicians and healthcare organizations to try to ramp up the volume of particular episodes, for example. There's always concerns in both types of models whether there may be some sort of case mix effect. In other words, is there some selection towards patients who may be preferable, particularly on an unobservable dimension, unobservable to a payer, for example. There's a lot of interest in how can we standardize care. There's also a lot of interest in do these models actually generate some kind of practice spillover, where not only does, for example, a Medicare patient benefit under a Medicare model, but do private payer patients also benefit because of a Medicare model that is generating practice-wide types of change. I highlighted that there are multiple mechanisms of participation, chiefly voluntary versus mandatory, and we could debate whether one of those has advantages based on the empirical literature. But here, what I wanted to focus on is overlap with other APMs. So how do population-based models tend to overlap with episode-based models or specialty-based models and vice versa? And is there empirical evidence? And to some extent, what is the empirical evidence that this may be good or bad when we think about it from the perspective of the patient? Next slide. So one question we may ask is, why does it matter in the first place? CMS has stated that there's a goal to try to get to near universal participation in value-based payment models in the near future. This likely means that we need a comprehensive strategy that will require both population and episode-based payment models. Again, if we kind of rewind back to the Post-Affordable Care Act era over the past decade plus, we've seen a lot of testing of different models. These have included population-based models like the ACO programs. These have also included specialty-based care models like Dr. Fowler highlighted, a number of them, BPCI, BPCI Advanced, CGR, etc., oncology models as well. And they have, in essence, collided. They have overlapped, although we may not have been able to coordinate them or strategize around how they may have collided in some sense. So as we go forward and we think about using both of these vehicles to try to transform care and hopefully reduce the cost trend for our national health system, we must think more proactively around how we might harmonize these models across the continuum of care, noting that population-based models are heavily focused on the continuum of care, as well as in the context of acute phases of utilization that may be related to specific diseases, specific events, think, for example, a heart attack or a stroke, or specific sites. So, for example, thinking about chemotherapy in the context of a physician's office or a hospital outpatient department. There certainly could be synergies between models, and we have seen those to some extent. So population-based models, for example, have done exceptionally well at reducing hospitalizations, whereas specialty-based models to date have heavily focused on reducing institutional post-acute care, both in a fairly complementary fashion, or there could be redundancies where the care infrastructure used, for example, thinking about home health use under episode-based payment models and additional ambulatory infrastructure that is deployed as part of ACOs may in fact be redundant. Medicare policy to this point, as I mentioned, at least prior to the current administration, has not been very outward, at least outwardly trying to coordinate these models. And to some extent, in the puts and takes of trying to create a financially solvent program as well as a financially coordinated program without too much double paying or double dipping, we have ended up in the policies that probably have been more discouraging rather than encouraging of model overlap. Next slide, please. So I'm going to dive a little bit more deeply into the evidence here, specifically focusing on a study that I did with colleagues at the University of Pennsylvania, at the University of Washington, that examined what happens empirically when there is impact between ACOs and overlap between ACOs and bundle payments, and what is that impact on patient outcomes. Secondly, we vary this looking at, or we explore how this varies for medical conditions such as acute myocardial infarction, congestive heart failure, COPD exacerbations, versus surgical episodes where the canonical example has been hip and knee replacement surgery. Next slide, please. To give a few study details, just to orient you to the institutional setting of this study, here we're focused on ACOs, specifically ACOs that were participating in the Medicare Shared Savings Program between 2012 and 2018. For bundle payments, we're focused on bundle payment episodes under episode initiators from 2013 to 2018. We are focusing here to some extent on the bundle payment effect and seeing how that varies across beneficiaries who are already aligned with or attributed to an ACO versus those that were not. We attempted a number of statistical and econometric techniques to try to address some of the confounding that might exist. And here we're looking, for example, at within ACO comparisons. So we're looking at if you're within the same ACO and one patient goes to a BPCI hospital versus a non-BPCI, another patient goes to a non-BPCI hospital, we're using that dimension of comparison to make comparisons within an ACO. And in the bundle payment context, we're looking within a hospital. So if there's a hospital that's participating in a bundle payment, we would then compare patients who are attributed to an ACO versus not within an ACO. And that allows us to control for, perhaps not eliminate, but at least control for many of the different selection issues. For example, that ACO patients may be different than non-ACO patients, or patients that end up in a bundle payment hospital, for example, may be different than those that do not end up in a bundle payment hospital. Next slide, please. So without further ado, the results here. So first, what we found here is that overlap in ACOs and bundle payments lower spending for medical conditions. And to be very clear here, these are gross savings, meaning these are savings relative to usual care, if you will. These are not net savings to the Medicare program. And unfortunately, we weren't able to do the calculations here to know, given the complexity of the dynamics across programs. Nonetheless, what you can see here is that if we look at post-discharge institutional spending here, so this is spending on readmissions, SNFs, IRFs, for example, and LTACs, long-term hospitals as well, we can see that the non-ACO group also decreases to a certain extent. That's the leftmost black bullet. Then we see that the ACO group, in fact, decreases more. That's the orange bullet in the middle. And if we compare the non-ACO versus the ACO, we get a blue bullet point and a range there. And that's the estimate of the difference between the ACO and the non-ACO. And this was a statistically significant, about $300 per episode of savings. Next slide. This effect of savings came chiefly from relative reductions in readmissions, which is what we highlight here in the box for ACOs versus non-ACO patients, as well as for discharge to skilled nursing facility and inpatient rehab facility, which is the set of blue points that is the kind of sort of third set. So once again, one of the things that's interesting, however, is you can note that the readmission rate itself is reduced for patients who are attributed to an ACO who end up with an episode at a bundle payment hospital. And that difference between ACO and non-ACO patients is in fact statistically significant for a reduction in readmission rates. Next slide. I should highlight that the prior 2 points I was making were for medical conditions. Now here we're switching gears to look at surgical procedures. So again, thinking about hip and knee replacement surgery, other orthopedic surgeries, coronary artery bypass surgery as the type of surgeries that are included in this study. Here you can see that we see a smaller but significant reduction in readmission rates, again, in the context of overlap between ACOs and bundle payments, another difference that is statistically significant. Next slide, please. So what we took away from this study, what this study seems to suggest, is that bundle payments seem to work well together with other value-based payment models, at least here in the context of accountable care organizations or population-based payment models. This resulted for medical conditions or patients admitted for medical conditions in lower spending and fewer readmissions relative to usual care, if you will. And on the surgical side, led to fewer readmissions, but no evidence of lower spending. This was the first evidence at the time, and I think to date, of synergies and overlap. And one thing that's interesting that I didn't show you the empirical data for is when we stratify the savings and stratify the quality gains of reductions in readmissions, we see, in fact, that these benefits of model overlap seem to be larger when clinical complexity is larger. So, for example, patients with congestive heart failure tend to have much higher ACC scores or Elixhauser comorbidity index scores. They tend to be sicker on average than a patient undergoing a knee replacement. And the effect sizes that we see are larger for those conditions with more complex patients, as well as directly for more complex patients versus less complex patients. These findings are important for policymakers to consider in the context of deliberate policy design to think about fairly distributing savings. And with a question mark here, we highlight, are there mechanisms in which we might try to encourage overlap between these models? Next slide. So in thinking through this, Will Schrank, Michael Chernew, and myself, we put together a potential approach to think about how we might harmonize models and term this hierarchical payment models. This was a viewpoint that was published in the medical journal JAMA. Next slide, please. To quickly highlight what we were suggesting, we were focused here on a global budget of a population-based model as the, quote, umbrella of accountability, unquote, under which episode-based payments are applied. The idea here is that ACOs, with their population level and total spending level view, would serve as a coordinating entity, and the episode-based payment system for specific conditions and procedures would sit underneath that umbrella of accountability. we review some of the empirical evidence for why this might be a good thing to do, as well as to try to understand how the organizational dynamics, or try to think about promoting a model which recognizes the organizational dynamics between the types of organizations that are accountable for episode-based versus population-based models. Next slide, please. There's a thought of how we might do this to drive the right types of efficiencies. And here's a few examples of why we might get some benefits from this kind of hierarchical coordination. First, we might stimulate more collaboration or closer collaboration among primary care clinicians who are so central to population-based management, specialists and facilities who tend to be even more important, if you will, to specialty-based models. We could create a blueprint and flexibility for reimbursing specialists and facilities within this coordinated model structure. You could imagine a system where organizations and population-based models would in fact earn savings by directing referrals or episode-based care from more efficient episode-based types of providers, and clinicians providing care under episodes would earn savings only underneath those episodes, if you will, for generating additional savings. This would preserve the episode-based payment model, which has been, to some extent, harder to get right in terms of some of the financial accounting steps, and support continued innovation across the care continuum. Next slide, please. The last point I wanted to highlight is that we have to be very, very thoughtful here, even in thinking about coordination, that value, at least as we have defined it in the first decade or so post-Affordable Care Act, does not equate to equity, and that we need to integrate equity concerns into our value-based approaches. There are reasons to worry about this. So first, greater financial accountability in physicians and hospitals has not historically led to more equitable outcomes. Risk adjustment tends to be more incomplete for marginalized versus non-marginalized groups. And there is some evidence that clinicians may avoid patients from marginalized groups and or even outright avoid participation in value-based payment models if they serve a disproportionately more challenging population. An approach to think about this in the context of value-based payments is to make equity an explicit goal, as the current CMMI leadership and administration has done in any value-based payment model. In other words, build equity into metrics and financial incentives. And I think we're going to hear from Mark Friedberg more about the work that Blue Cross Blue Shield of Massachusetts is doing directly in this setting, as well as measure this notion of disparate impact on access and quality for disadvantaged populations by expedited reporting and data collection. Very important to think about the monitoring aspect of this to complement the proactive piece. Next slide, please. So here I'll wrap up. Thank you again for the opportunity to come in and present these thoughts and empirical findings with you, and I look forward to the discussion that follows.
Thank you so much, Amol. Very timely for our discussion today. We are holding all questions from the committee until the end of all the presentations. Next, we'll hear a presentation from Dr. Mark Friedberg, who is the Senior Vice President of Performance Measurement and Improvement at Blue Cross Blue Shield of Massachusetts. Please go ahead.
Yeah, thank you very much for inviting me to speak today. I thought, Dr. Navathe, your presentation was great and really set up, I think, in the way you just alluded to, some of what I'm going to get to in this deck. Let's go to the next slide. What I'd like to just share with you is how our company is thinking about evolving and expanding quality measures within total cost of care contracts within our own version of an ACO type contract, which is called the Alternative Quality Contract, or AQC. So first, our longstanding principles for using high-stakes measures won't change. Payment is a high-stakes measure, as are other uses that have direct economic consequences for provider systems and for individual clinicians, such as public reporting and tiering. For us to use a quality measure, it has to be valid, meaning it measures what it's supposed to measure or purports to measure. It has to be important. And it has to be reliable, so has a favorable signal-to-noise ratio for the level at which we're using the measure. In general, moving forward, we're pushing on importance to try to move quality measurement into new areas where we currently have blind spots in our existing measure slate. And I'll say that reliability is an ever-present concern. it basically serves as a filter on validity and importance. We start with those two criteria. Whatever makes it through that initial screen, and that's a slim list, then gets further filtered by reliability. And this means that for different AQC organizations, which vary in size, the measures that are on offer can vary a little bit. Those who are the larger organizations have a wider range of measures than those that are the smaller organizations and may lose some measures due to reliability concerns. Now let's go to the next slide. So on improving measure validity, one area of interest for us, and this is a longstanding research area that we are actually looking at ways of piloting in a lead up to high stakes measurement, is explicitly measuring the performance of shared decision making. So briefly, this is defined as the degree to which decisions are made in a way that's consistent with medical science and also consistent with individual patient values and preferences. This is, to our mind, unquestionably superior ethical construct than following guidelines in general for a broad population. If you look at many of the USPSTF recommendations, there is a mention of shared decision-making in there as the optimal way to proceed. But then if you can't do shared decision-making, you do the second best thing, which is to follow the guideline. That ends up being the basis of most legacy measures. We'd like to see over time, and we understand this is a big change, shared decision-making measures replace most legacy measures for primary care, so measures of cancer screening, chronic condition management, you name it, because there are trade-offs to all of these services, and patients do vary in their values and preferences. And applying a single set of values and preferences that's set by a guideline committee is probably going to be suboptimal for many patients. We believe the best way to measure these is to use patient surveys. Dr. Karen Zapuka at Mass General Hospital, for example, is just one of a couple of organizations out there that have really pushed the envelope on this and have generated NQF-endorsed measures of shared decision-making. So it can be done. The key challenge is going to be uniform fielding methods. It's going to be a little bit expensive to do this the right way, in our view. That might not be to go through providers and ask them to collect the data, since providers are already very busy, have a lot on their plate, and that can introduce unacceptable fielding method variation from provider to provider. If we're trying to compare providers, we probably need to get that washed out, and that'll include some kind of fielding method that's akin to CAPS, where there's really very little variation, if any, if you're using an approved vendor. We have a longstanding interest in patient-reported outcomes as well. And again, fielding concerns are huge there. When we move from patient-reported outcomes to PRO-PROM, so patient-reported outcome performance measures, now we're using them for high-stakes uses. We do need to deal with the heterogeneity in fielding issue. I'm a practicing primary care physician myself. I see in my clinic, and I think I would encourage everybody who's interested in these measures to do this. Watch these measures being collected in person in even a well-resourced clinical setting. It is very eye-opening and really, I think, argues for much better and much more focused attention on the fielding methods. Finally, we are strategically trying to really up our game on mental health services, starting with patient-reported access to mental health services. There are administrative measures of network adequacy and out-of-network use of mental health professional services that are available already, but patient-reported access is probably a way to go in the future to get it more meaningful. We need to ask our members how hard it was to find mental health services, to even find out if they were frustrated enough that they were not able to actually find mental health services at all for a mental health need they may have. And those kinds of scenarios are not always visible in existing measures, so that's another area of active development for us. Let's go to the next slide. So now talking about extending high-stakes measurement into new and important areas, here I'm going to talk a little bit about our efforts on equity measurement. So we define equity as differences between groups of patients for which no systematic differences are ethically tolerable. So racial and ethnic inequities would clearly fall into this category. we've already, as of about a year ago, I think it's actually exactly a year ago today, we published an equity report on our website. I think we're still the only health plan to have done this, which is a surprise to me. Of all of our HEDIS measures for which we had a sufficient sample size, so that's about 46 HEDIS measures for calendar year 2019 on our website. We'll be updating that later this month with 2020 and a revision of the 2019 report, plus a couple of CDC measures for severe maternal morbidity, since that's a Blue Cross Association priority. This was intended to, first off, just be transparent about the inequities that we see even within a commercially insured population. They're large. It's humbling for us to have seen this internally first and then to put it on our website. Secondly, it's to signal seriousness to our provider network that we are moving with speed towards high-stakes measurement on equity incorporated into those AQC contracts, so into an ACO-type program, and to enable all of our stakeholders, our members and our accounts, most importantly, to hold us accountable for making improvements in the equity of care that our members receive over time. We'll be updating this again every year, and a big obstacle to all of this, of course, was gathering enough race and ethnicity data that we could even test such things as statistical imputation methods for race and ethnicity, which is the basis of this report. Below this, I want to talk a little bit about clinical rationale. This is really relegated to the research realm right now. There are no measures NQF endorsed for measuring clinical decision-making rationale, but this is actually a very old quality measurement method. Structured implicit review, meaning having peer clinicians review each other's decision-making rationale, can be first off, universally applicable and can really move us into specialty care where we lack many important quality measures. By and large, this is true for HEDIS, this is true for our contracts as well. The measures are focused on the primary care setting. But we think this is an area of promise, and will, of course, in this case, not be doing this directly with our members. This will involve setting up structures and incentives for providers to do this with each other within the context of the alternative quality contract, and that'll be going on a pilot basis for some time before it's ready for prime time on payment. Let's go to the next slide. And I'll return a little bit to the way we are incorporating equity into all components of the alternative quality contract. So payment always gets the most attention when we think about the AQC, but I think that's a disservice to the other two components, the data and support that accompany the payment incentive. Those are, I would say, at least as important as the particulars of a payment arrangement, and those have actually gone first when we moved into equity. So in addition to publishing on our website an equity report for our in-state members, we gave every single one of the AQC providers last year a report of their stratified by race and ethnicity AQC measures. And most of them had never seen this kind of thing before. They didn't have the capability to track this internally. For those who had, the thing they'd never seen before, which we gave them, was comparisons. So this was a confidential report, but they could see in a blinded fashion if they had, let's say, a 10 percentage point gap in hypertension control between their black and white members of our plan. How does that compare to other AQC groups? Is that a large inequity, a small inequity, somewhere in the middle? Now they all know the answer to that question, and that can be, we hope, guiding and motivating for making investments in equity improving activities. Support is something we launched last November in two ways. So first off, I'll just say a little word about support in the context of the AQC for the last dozen or so years of its existence. This has always been a component of the program, and I think one that really distinguishes it from many other ACO-type programs. We invest a lot in giving tailored guidance and explanation of data and ideas for quality improvement with each AQC group. I have a team of folks. This is all they do. Each one of them has a handful of AQC groups that they are basically the QI concierge for. And one thing we knew we needed to do for equity was to improve our ability to focus on equity specifically with that team, which didn't really have that emphasis historically. So we contracted with the Institute for Healthcare Improvement, or IHI, which had 5 years of experience in coaching providers on equity improvement at the time we contracted with them last year. They've been our partners in kicking off an equity action community, which is a way that we gather all the AQC groups. They're all participating in this to share best practices, share learnings on how to approach equity as an improvement target. and to get individualized coaching sessions. And that's really the phase they're in mostly now. Most of the meetings they're in are individualized with one of my team members and one of the IHI equity improvement consultants. And that'll go on for at least another year with IHI. In addition, as a down payment on the payment component of this, which is not yet in force, we granted $25 million to the IHI at the end of last year, which was one of the largest grants this company's ever made, to distribute to the AQC providers, plus some of the smaller providers who are interested in equity that are not large enough to be in the alternative quality contract. For three purposes. The first is just to defray the cost of participating in the equity action community. It is costly. It takes time and effort of highly trained individuals within these provider organizations to participate in those sessions, but also to for many of them upgrade their internal race and ethnicity data. It's like turning over rocks with many provider organizations when we started to get into detailed discussions about the state of their race and ethnicity data. Some were in a very advanced stage, but many were not. They might have multiple different EHRs, never really looked at how complete or accurate the race and ethnicity data were in those many instances, or even the data standards that they were on. It was not all that uncommon to find a data standard being used within a part of an organization that exists nowhere else in nature, not consistent with OMB, not consistent with FHIR. So there's a huge investment there that we think is very important so that these organizations can track their equity performance in real time. In addition, for many of the groups, they are in their grants that have been awarded focusing on one or more AQC equity measures. And these are, generally speaking, in the chronic disease management area, a lot of interest in diabetes and a lot of interest in hypertension control, and some interest as well in cancer screenings. It's not a surprise if you look at our public equity report. We have large inequities in all of those areas statewide. Pretty much all the AQC groups have those same internal inequities to some extent, and so it's a common target for them. And we triple weight those outcome measures in the structure of the AQC contract in general. We're doing the same weighting for equity. So those are great places to make investments from the standpoint of sustainment of the program, which will come in the payment component. That's the third piece. And those will be live for at least some groups as of January 1st of 2023. We are not yet signed with anybody, but once we do, we will be publicizing those. So stay tuned. Somewhere between 1 and 5 groups, I expect, will be live on Pay for Equity starting January 1st. Let's go to the next slide. No, that's my last slide. So thank you very much for your attention, and I look forward to the remaining discussion.
Thank you so much, Mark. Very interesting as well. Next, we have Dr. Eric Schneider, who is Executive Vice President of the National Committee for Quality Assurance. Please go ahead, Eric.
All right. Thank you very much, members of the panel, for the opportunity to be here with you today. And thank you, Dr. Navathe and Dr. Friedberg, for the fine presentations and the fine work that you're doing. My comments today are going to focus on the topic I heard yesterday from Dr. Liao that the selection and use of performance metrics is among the top design considerations for physician-based total cost of care models. So I am going to focus today on quality accountability systems and describe how we at NCQA are thinking about an infrastructure for quality accountability and measurement that can better support value-based payment models of many types in the future. With a bit of background, studies comparing healthcare in the United States to care in other high-income countries show that in the U.S., health professionals have the capability to deliver excellent clinical care, outstanding in many cases. However, Americans face many challenges in three key areas. The access to care, coordination of care, and equity of care. These challenges have a pretty adverse impact on health outcomes, and addressing them needs to be at the heart of our consideration of any payment model that involves the total cost of care. But neither access nor coordination nor equity are well measured given our current health data infrastructure and our approaches to performance measurement. So what I'll try to do in these remarks is ask the question, what quality accountability infrastructure is needed to support payment models based on total cost of care, and how will quality accountability systems address what I just described as the three as key drivers of both health and spending. and those include unmet social needs, community inequities, lack of access, and other things. If we go to the next slide. So I think that the issue of unmet social needs is something that has clearly come to the fore, and the association of unmet social needs with poor health outcomes is also something that's well documented. It's estimated that anywhere from 40 to 55% of health outcomes are attributable to social determinants of health that occur outside the traditional healthcare system. Doesn't mean the healthcare system can't play a role, but in fact, it has to play a role. But we know that, for example, infant mortality rates are higher among Black and Native American populations. Hispanic individuals are more likely to die from viral hepatitis. I won't read the slide here, but you see that the total cost of health inequities and premature death is actually a huge cost to the system, and actually one of the reasons why thinking about how the healthcare delivery system can respond and create those savings, as well as address those inequities and problems due to unmet social needs, so important. If we go to the next slide. The other thing that's sometimes not fully appreciated is that the unmet social needs are broadly felt across the population. So this, about half of respondents in a survey, a recent survey, reported at least one unmet social need, with around a quarter reporting two or more unmet social needs. And the bars on the right show you sort of overall by payer, how those numbers break out. And you can see that among Medicaid and the uninsured populations, obviously there are more unmet social needs, Medicaid in particular, but that also has to do with the eligibility criteria for Medicaid. But more importantly, the unmet social needs are reflected in all of the different insured populations: Medicare, individual insurance, group insurance, that's employer-based insurance. There are just profound unmet social needs throughout the insured and the uninsured populations in the U.S. Let me go to the next slide. So the point being that a physician-based payment model, presumably the physicians participating in that payment model will see unmet social needs in their practices, regardless of the payers that they actually are engaged with. I want to highlight a few how NCQA structures its accountability program thinking. There are three programs. The first is the HEDIS program, the HEDIS Performance Measurement System for comparing health plans. That's a comparative performance measurement system that's been around for 30 years now and has evolved. But the central notion is the idea of measurement to make comparisons, and in payment-based incentive programs to actually adjust payments. The second is our health plan accreditation program. So accreditation for health plans is about making sure that health plans have the structures, capabilities, and processes in place to serve their enrolled members. And then third, maybe most important for this discussion, is our recognition programs. The patient-centered medical home recognition program probably being the most widely known. And in those programs, we also have diabetes recognition program, a stroke and cardiovascular recognition program. But in those programs, the concept is to evaluate the structures, capabilities, and processes in place for clinicians and teams of clinicians and practices to deliver high-quality care. And I think that third one is the first and the third, to me, are fundamental to thinking about total cost of care programs. Go to the next slide, please. Can I have the next slide? So I have spent 30 years of my career in evaluating performance measures, developing performance measures, and studying how they're deployed and used in practice. And I also have now, I guess 30 years later, have a keen understanding of the limitations of comparative performance measurement. And I think one of the key, as we have moved into the sort of work that Dr. Friedberg described on measuring equity, that highlights actually many of the challenges that are not just in the equity area, but throughout performance measurement. But to enable fair comparison and precise and accurate comparison of hospitals, teams, practices, plans, you name it, there are always going to be challenges around two major issues. The first, well, they may always be there. The first, though, will always be there, and that's how do you sample, how do you get large enough samples to get an accurate and precise and valid and reliable comparison. So that sampling issue is probably one of the key constraints that we face. And then the second is around the data and the data we have available. That's the one that's potentially addressable through our approaches and actually can help a lot with addressing the first. I put on this slide the comparison of organizations on quality and equity requires pretty large sample sizes. We've seen this over and over again in developing HEDIS measures for health plan comparison, that it requires fairly large populations to be able to measure the quality of care for even some common preventive services. For when we get to chronic conditions, that's even more challenging. And when we get to stratifying by race and ethnicity, where 10 to 15 to 20% of the population may be in one of the two groups you're comparing, that poses special challenges. And I think the numbers typically would go beyond, for at least for this purpose of really nailing down valid and reliable measures to adjust incentives. It will challenge even the largest physician-based payment groups, groups that are associated with payment. So we're rolling out right now, and I think we'll learn a lot, as Dr. Friedberg was suggesting, about when we do stratify by race and ethnicity, as we are doing now in 5 measures in this year, measure year for HEDIS, and another 8 measures coming next year. We will learn a lot about what the challenges and limitations may be to that, to understanding equity as it rolls out in practice. And then, as he mentioned, also we're evaluating the data that are available to do this, because we are not quite where we want to be in terms of data. Next slide, please. So I wanted to also reflect on, and Dr. Navathe sort of set this up, the organizational capabilities that can support improvement. And what we have learned from the foundational work to create the patient-centered medical home model and the recognition program for that model. And I think an important insight is that, as he called the hierarchical approach to payment, is that these systems that can deliver high-quality, reliable care are necessarily nested systems that with foundational capabilities, such as leadership and quality improvement strategy, that then enable additional capabilities. So this model, this is the Ed Wagner model from about 10 years ago now. But the thing I wanted to point out here is that the two challenges that I mentioned, enhanced access and care coordination, are actually are in the 4th stage. They're actually built on a lot of other capabilities that need to be in place in order to be effective as a patient-centered medical home. The other insight that we've seen as the PCMH has rolled out is that the PCMH is only as effective as its medical neighborhood to some extent, and especially as we're looking at specialty and primary care joint models of total cost of care. We want to be thinking about the medical neighborhood and about those challenges, about the foundational elements that are needed to achieve high levels of coordination and access. Next slide. The other lesson comes from, this is an example, I guess, of another insight, which is that if you compare low-performing and high-performing practices in the PCMH set, these are all practices that have gone through recognition program. one of the things that really jumps out is that many of the functions of an effective patient-centered medical home rely on digital data capabilities, the ability to collect, analyze, exchange, and interpret data. And that's shown in this spider diagram. The practices that are sort of out at the edges of the diagram, or the functions where it's of high performing, almost 100% performing, are all associated with the ability to manage data effectively. And it's been said that data are the lifeblood of healthcare, and I think that comes across in this analysis. Next slide. So we are now moving into, I think, an area where I first wrote about the challenges of moving to a digital performance measurement system back in the 1990s. But we're now at the point where we can envision the standards, the health data standards coming into play, thanks to the Office of the National Coordinator for Health IT, to really bring together three areas that have been pretty disjointed and functioned almost in silos. One is the practice guidelines, the evidence management arena. The second is at the lower left of the triangle is the measurement, performance measurement activities. And the third is our processes for exchanging, collecting, transferring, aggregating, exchanging data. All of those have been operating somewhat in their own silos, and there's a cost to a lot of the manual process that results from the lack of coordination among these three activities. If we go to the next slide, what our vision for the future is that we need to really now start to marry these activities. So when we get to a point where guidelines are digitally enabled, clinical decision support is digitally enabled, and it's linked more closely to measures that are in digital format, and the data to support that, as we're now starting to see with new health data standards and exchange, enable us to marry those two activities. I think we'll be in a much better position to support the physician-based cost of care metrics. I'm going to go quickly here now. On the next slide is about that journey toward interoperability that's been underway for at least a decade and maybe more. But we're now beginning to look at EHR certification updates and data exchange mandates that will make much of this possible. I'm going to go to the next slide. So digital quality measures are really, I think, where the future is if we want to get effectively measure access, coordination, and equity of care. I won't go through the definitions here, but CMS has been very clear that this is the direction that the Medicare program is going to move. There are lots of activities underway to achieve health data standardization. Providers don't need to be deep in the weeds of this, but be aware that this technical infrastructure is coming that will make it possible to implement the type of program that Dr. Navathe was describing, of a sort of detailed ability to map the attribution and allocation of resources across teams, across provider groups. If I go to my last slide. So the conclusion here is that the quality infrastructure needed to support total cost of care models involves, I think, three pillars. The first is trusted consensus-based evaluation standards and methods for evaluating capabilities, not just measuring, but actually evaluating capabilities of the entities that would be part of the total cost of care program, and that those abilities and capabilities to provide high-quality care really need to be in place, documented. The second is we need better approaches to measuring and evaluating unmet social needs, barriers to access, coordination, and equity. And then finally, I think that all of this will rest on a pretty substantial investment in standardizing health data exchange that will, in the future, support novel digital quality and equity measures that will enable us to overcome some of the limitations of our past measurement approaches. So I'll stop there, and I thank you for your time. look forward to the discussion.
Thank you so much, Eric. Another really important perspective to consider. Finally, we have Brian Bourbeau, who's the Division Director for Practice Health Initiatives with the American Society of Clinical Oncology. I'll note that ASCO submitted a proposal to PTAC in 2020. Please go ahead, Brian.
Thank you very much. We can go to our first slide here, please. So, today I'll be speaking briefly regarding specialty care episodes and approach to nesting or carve out and how ASCO in its submission and in thinking about specialty care models have approached that issue. First, though, I wanted to share some numbers with the group, and this is a study that we did of 25,000 oncologists across gyn-onc, medical oncology, radiation, and surgical oncology. And what we did is access records within the quality payment program system for those oncologists. What it showed was a great participation amongst the specialty in the Medicare Shared Savings Program. Here you can see in the Medicare Shared Savings Program, there's some overlap in the numbers, but the total is about 11,000 of the total 25,000 oncologists studied who participated in one track or more of the Medicare Shared Savings Program in 2022, the July snapshot. And you compare that to OCM participation, which is a little over 3,100 oncologists there. And I bring this up because while OCM and its replacer, the Enhancing Oncology model, is certainly important in care of cancer patients, there is much greater participation in a multi-specialty population-based model in MSSP. And so we have to think about, specialty care within those population-based models, or else a significant number of patients will be missed in quality measurement and care delivery requirements. Next slide, please. And so I think oncology and cancer care is a great example of the complexity that we need to think about in whether to carve out, nest, or otherwise coordinate care between primary care and specialty care here. I worked, it's been 6-7 years now since working in the state of Ohio on Medicaid episodes for oncology. But just for breast cancer, we had 3 different episodes. We had the biopsy, we had the surgical mastectomy, lumpectomy episode, and then we had medical oncology episode. And each one had its own features of quality measurement and what was required for patient care and how to think about cost for each one of those. But certainly you have this complexity, diversity here, where we think about surgical and radiation within a defined time period, and what could be a nested episode there where overall coordination of care still happens at a primary care level. But then when you get into medical oncology, you get into this indefinite duration where the patient may be under medical oncology care for months or years. And how do you approach that? Does primary coordination of care rest predominantly with the primary care physician, or does it shift to the oncologist to where you think about a carve-out episode there? And then when we get into survivorship, we need to think about survivorship in at least cancer care as a chronic condition and the need for ongoing coordination of care between the specialist and the primary care physician. So if we go to the next slide, this is how, in trying to think, at least within my specialty here, of what is nested, what is something appropriate for a nested episode, what is something appropriate for a carve-out episode, And then what do we consider kind of coordinated care of indefinite duration where a patient has a chronic condition, such as being a cancer survivor, and still need that ongoing care coordination between the PCP and specialty care physician. But some of the differences here is in a nested episode, we may have a defined duration where we can see in radiation oncology, in the radiation oncology model that CMMI put forth, a 90-day duration to where you can really put that guardrails around it and say patients entering into the episode, patients exiting the episode in defined time. That is different in something like medical oncology in the oncology care model and other medical oncology models in Medicaid or private space where it can vary over time. And that indefinite duration of not knowing as you enter in to that carve out whether or not it's going to last for months or years is an important distinction there. The financial impact of those type of episodes in medical oncology also vary in time. So, in the first 6 months, that patient may have extremely high costs. And then if they are curative, eventually in survivorship, that cost is going to come down over time and the intensity of treatment. In other cases, the patient may progress in their disease and have more expense over time. And it is difficult to know that entering in, and they're impossible to know that in some cases entering into that episode. And then in the care management area, we think about in a nested episode, and thinking about for example, radiation episodes I've worked on, the care management and thinking about just kind of overall navigation, coordination of care. Certainly within the radiation treatment area, care management resides with the radiation oncologist. But in thinking about other specialties and, general coordination of care, navigation, addressing health-related social needs, financial navigation, and so on, there's still a lot that resides within primary care because it is, a defined duration of time there. In the medical oncology space, a little different. Medical oncologists employ their own patient navigators, their own financial navigators, social workers. They're addressing nutrition for patients and so on. And so that's why I think of medical oncology as a carve-out episode area because you are really shifting that care management to the specialist. And given the, I think a final point in here on data collection, when we're going to talk a little bit about overlap and data connection here, nested episodes, I think, are a great opportunity to reduce overlaps in data collection. If data collection is happening at a population level in primary care, is there a need to duplicate that data collection? I'm thinking even things as simple as social demographic data. Can we reduce those administrative requirements of the nested episode versus a carve-out episode of really thinking about the need for perhaps different data, different quality measurements, and of course, that exists within the specialist providing care under those type of episodes. Next slide, please. So some of the considerations for nested episodes, what we see, we've seen overlap within an OCM and the carve-out space with Medicare Shared Savings Program. There certainly was going to be overlap if radiation oncology had moved forward. And as part of that, there were duplicate discounts applied here. And so, there's discount in one area within the population health models, but then also discounts applied to radiation episode payments. And, if you read through Enhancing Oncology model that CMMI put forward for next year, there is a great deal of financial reconciliation if you participate in multiple models there. It's really scary to think about. And I personally, my former practice, we participated both in Medicare Shared Savings Program and OCM. And one of the pain points was figuring out what payment was made to the ACO and performance, how does that impact payment made under OCM and vice versa there. And so this is something that has to be thought about in trying to nest episodes. Second is that duplicate and sometimes conflicting quality measures, where a patient who's already tracked in, for example, patient feedback under CAPS under a population-based model is then also, tracked for a specialty model. And these patients are receiving multiple surveys and you have to think about coordination of surveys there. And so sometimes there's these duplicate and conflicting quality measures that we need some administrative simplification. And I already talked about the data reporting aspect of that, where you have two parties trying to collect some of the same data for patients, and how can we reduce that burden. Next slide, please. That differs from the carve-out episode area, and how we think about medical oncology. I'm going to spend a little bit more time on this because this was our submission to PTAC in the patient-centered oncology payment model. And the way we looked at that was our disease episodes really included a shift in the responsible provider. The medical oncologist was responsible for patient engagement and education. They were responsible for navigating the patient through different aspects of care management, including with other specialists, when they need to go other specialists for care, when they needed tests, and so on. We had data collection requirements for the oncologists, including, social demographic data and health-related social needs, and then financial navigation. So we required that the oncologists have financial navigators review cost of care for patients. We also had the differing quality measures and performance scoring. And so we were looking at different things than a population-based model that the patient could also be under looks at for quality there. And there was a need for additional, disease data that didn't exist within population-based models. And so what we thought about quite intensively here is the care delivery requirements that we were going to put on specialists and the measures really focusing on handoffs. Because if you talk about a carve-out and you talk about a shift in responsible provider, it is, imperative that you think about that handoff and communication between primary and specialty care. So next slide, please. We're going to move past this one because I think it's just repeating some of the things that we mentioned in care delivery requirements and talk about these handoffs. So some of the care delivery requirements that we put in there and put some measurement to is first the handoff between primary and specialty care. What did we expect an oncologist to do when they were provided a patient from a PCP? And the first one was patient education, letting them know what are they going to expect as during that handoff, who is their new care team, how to contact them, responsibilities, and so on. Communication back to the primary care physician on the individualized treatment plan. What is this patient going to receive? And that includes different coordination of care beyond just their primary treatment. And then ongoing communication as patient status change, treatments change, referrals to other specialists. And then finally, the handoff back to primary care. So thinking about the survivorship care plan, treatment summaries, here's what the patient has received over their time in this carve-out episode, and what follow-up care is necessary between primary and specialty care. Next slide, please. And so we put different payment phases into this model and really think about what is carve-out and then what is what we call active monitoring and survivorship, where there's coordinated care. Next slide. And then, after that patient's, kind of primary episode had ended, there is a need here in coordinated care to really think about, for patients with chronic conditions, how does an ACO really share in care management, coordinate care management fees based upon individual patient needs, and really support that ongoing collaboration. Next slide. And then lastly, I think it's important, as we think about an ACO-based model and specialty care model, sometimes these participants aren't in the same health system. So the health system may have a primary care specialist and lead the ACO, where independent oncology practice or other specialists are in the specialty space. They have to think about it, and really it's hard to design this within your model, but they have to think about it in their relationship, some of the other economics of an accountable care model, and how to address things like leakage, where the ACO may be focused on that as a health system, yet here the specialist is independent of that health system. And next slide, please. So that's the end of my opening remarks. Thank you.
Thank you so much, Brian. Very helpful analysis for us to consider. Next, we're going to go and open up the discussion to the committee. If you have a comment or question, if you could place your name placard on its side, and we'll ensue the discussion. Who would like to go first? Paul.
Thank you to all the speakers. Very interesting presentations and very helpful. A question for Dr. Navathe, but others also feel free to provide their view as well. Dr. Navathe, on one of your first slides, you talked about primary care or population-based versus specialty care-based. And on the specialty care-based, you highlighted that there are more options for policymakers to incentivize participation. And so then I'm just wondering, when you think more broadly about incentives, as we're thinking about specialty models within population health models, in your view, what are the most promising incentives for encouraging that sort of clinical coordination and integration between primary care and specialty care?
Thanks, Paul, for a great question. So I just want to make sure I'm understanding the question exactly. So you're saying when we focus within population health-based models, or population-based models, what are the most effective incentives or reflections on incentives to coordinate between primary care and specialty care?
Yeah, and I guess more broadly, how to engage those specialists within, and if you think about an ACO, because you present a lot of data around the ACO and specialists as sort of within the bundles within ACOs, and the being more effective. In my experience, I've found it's still very difficult to engage specialists in general within these ACOs. And I know you've thought about this a lot. I mean, what within if you have bundles within the ACO or you just have specialists within ACO, how best to incentivize that, whether it's around care coordination or managing patients, whether they're in a bundle or just part of the ACO?
Sure. Thank you for the clarification. So I think it's a fantastic question. As you're highlighting, outside of this notion of deliberate overlap between a specialty model and an ACO, I think we have not yet seen systematic coordination between specialists and primary care at the scale that perhaps we want to. And so to some extent, I think it's a question of maturity of the ACO, using ACO as an example here. So I think there's, advocates of ACOs, and I certainly consider myself to be one as well, who would say, if you think about the hierarchy, if you will, of low-hanging versus higher-hanging fruit, most of the lower-hanging fruit approaches and opportunities for ACOs do reside in the primary care infrastructures area. And so I think it's not surprising, one, that we have a huge system that's hard to shift directions on. And so most ACOs, most organizations have focused on primary care as the, quote, lower-hanging fruit, if you will, and invested in that infrastructure. I think that being said, if we take a step back and we look at some of the more sophisticated, more mature types of organizations that have been exposed to financial risk before its ACO participation, participate in some of the more financially stringent, if you will, ACO type models, they have made some progress, and they have had success in a variety of different specialty care areas. Certainly, for example, in reducing hospitalizations, as I mentioned, but also in the post-acute care space. And there's some emerging evidence even in the oncology area that overlap between these models and ACOs in general. Sophisticated ACOs may do better in managing complex patients. So I think the evidence is, to date, there's not ACO models writ large that are generating those types of effects, but I think the sophisticated ones most likely are. That brings us to your actual question. So I kind of reviewed the evidence really quick. Your actual question is, so what works, right? And I think probably the simplest answer I could give is very explicit, concrete incentives that are directed to the specialist. Because if we take the general ACO incentives, they're not directed necessarily to the specialist. In fact, we're depending on the middle layer, if you will, of the ACO organizational structure to then translate those incentives down. And as I mentioned, the preponderance, the large majority of those incentives are actually not sitting directly within a particular service line. And I think that's our hypothesized reason for why, when you have specialty-based models that are sitting alongside the population-based models, we get this synergistic effect, because now the cardiologist like yourself, Dr. Casal, the oncologist, the rheumatologist, whoever it is, the orthopedic surgeon, they're engaged in practice transformation. They're reviewing their data. They're thinking about what the most appropriate post-acute care setting is, and perhaps they're actually coordinating. There is some infrastructure overlap to some extent that I think we need to think through. So in general, ACOs have invested a lot in ambulatory infrastructure. They tend to do great with post-discharge follow-up visits, for example, in the next 7 days, and they tend to do that with a PCP or an NP or somebody like that. Specialty-oriented models have tended to rely much more on home health workers, for example, home health aides, home health nurses, and that is duplicative to some extent. But I think the simplest answer, again, just to restate it, is having an explicit approach to specialist incentives within a population health construct is imperative. We can't just depend, if you will, on the total cost of care umbrella incentive from being translated down to fairly concentrated, focused specialties where we might not see that.
Thank you very much. I don't know if any of the other presenters, again, either from the quality performance lens or others, how to best incentivize.
Yeah, thank you, Dr. Sal. I'll jump in because I think one of the things we've learned out of the performance measurement initiatives over the last 20 years is that creating that joint accountability around patient-focused measures, patient-focused outcomes can produce or make possible the cultural change, which is around how do we, as a team, provide the best care and the best outcomes for particular patients with particular conditions. Where it may fall short is that we have patients with multi-morbidity, patients with multiple complex conditions, and then the measurement enterprise gets to be challenging. But I'll say in my own primary care practice experience, we used to operate even within the primary care practice in a fairly siloed way. It was when diabetes performance measurement came into the practice and then financial incentives followed on those measures, that we did the work of reorganizing the care to make it more team-based. And the patient-centered medical home is sort of the next extension of that. And this sort of there is a progression that's needed. But I think performance measurement and the sort of explicit accountability requirements that Dr. Navathe mentioned can be very helpful in that regard. One example would be the data exchange example. We don't have great incentives in the system for providers from different parts of the system to exchange data with one another that could be helpful. I think that was highlighted by Dr. Bourbeau as an opportunity. And I think the more we make it a sort of a condition of participation that the system exchanges, that the participants exchange data so that we reduce some of that redundancy in the system, those sorts of quality standards or expectations can be helpful.
Yeah, I just want to bring up, I think Dr. Navathe correctly, said that the financials often get lost within the ACO, and they shouldn't, but it's a common feature in a population-based model to perhaps adjust financially based upon patient risk. And so, if you have two examples, one example is you adjust care management payments for an ACO that has higher risk patients. And you say, okay, well, now you're going to get 10% more than an ACO that has less risk patients. Often those financials get lost. If rather that difference in care management payment and what you expect from that service follows the patient, and you're saying a high-risk patient with multiple conditions is going to receive, $200 care management versus $15, it is much easier. You've laid it out for the ACO to then coordinate that care amongst multiple providers and enough dollars to go around there in incentivizing coordination.
I want to say briefly, we see some inexplicable things sometimes within provider organizations about how specialists are paid, given how we pay the organization. And that has to have one of three explanations. First, either we don't have the contract right, we don't have the incentive strong enough, we don't have the right kind of business case on an accrual basis for the organization to make an investment and really change how it incentivizes its subspecialists financially or otherwise. Second explanation is a cash accounting issue, and I think this probably is an attended to issue in the construction of alternative payment models. If you're paying fee-for-service along the way with a settlement of a shared savings payment that might come 2 or 3 years later, the organization has a cost of cash they have to deal with a float. That's a real problem for many organizations, and for that reason, they end up churning fee-for-service for some service lines just to maintain the cash flow, and sometimes it's a subspecialty line, which works against their long-term interests, our members' interests, our accountants' interests, everybody's interest in the long term. But the short-term thing has to be solved. There's lots of ways of doing that. Get off of fee-for-service to the extent you can. You give advances against settlements. Anything like that could be explored. The third is the possibility the organization just doesn't really understand the incentives that are put in front of them. It's very easy to construct complicated incentives. Organizations may need help understanding when they have an internal payment structure that really goes against their long-term interests.
Very helpful. Larry.
Very stimulating presentations this morning. I'd like to direct my question to Mark Friedberg. You are the sole representative from a health plan in this panel, and I was impressed with the degree of change you are building inside your ACO models with patient-reported outcome measures and social determinants. And it begs the question to me, how prescriptive are you getting within your ACO contracts? Are you trying to construct skeletal infrastructures inside these ACOs? Where do you draw a line between what you're trying to accomplish from the health plan point of view versus flexibility you allow to the designers of the ACO itself?
Yeah, it's a great question. We are pretty agnostic as to how one of the AQC groups or the ACOs chooses to fulfill the goals of the contract. So we want to be very clear about what kind of activity we're encouraging and what the outcome measures will be that will result in financial favorable settlements for the organizations, but we don't get into here's how you should pay your physicians, here's what you should invest in necessarily, with the exception of those grants. When those grants went out, groups had to apply, and IHI ended up making the awards ultimately. But there, I would say a different filter was applied because that was startup money without attachment to outcomes. But once it's attached to outcomes, and by the way, the amount of money on pay for equity is going to dwarf that $25 million on a long-term basis for these groups. we can be, I think, pretty sanguine about how the groups choose to solve problems internally and make investments internally, because they have to work in order for them to have a business case to make those investments. So there won't be a whole lot of what I would call equity theater going on within these organizations. That would not prove out on the kind of measures that will give them a payout from us. Another coordination problem we have is we're only one payer, and we are the largest commercial payer in the state, but we don't account on our own for the majority of almost anybody's panel. So we're trying to coordinate as best we can, understanding we're the first on pay for equity in our market with everybody else. And what that means is really just sharing our designs with other payers in the hope that, when they stand up their own pay for equity programs, first that they'll do it. Hopefully, what we've done will help them stand up those programs just in terms of how it could be constructed. But, if it isn't identical to us, at least it should rhyme so that the kinds of investments that an ACO might make to get a payout from us will also serve their contracts with other payers, including MassHealth, our Medicaid program.
Look forward to hearing more about that work. Chinny.
Thank you, everyone, for your presentations. So wanted to direct this question to Dr. Schneider and then Dr. Friedberg, as well as everyone else. When you're thinking about pay for equity and collecting data, how are you approaching the variability in data and ensuring that there's consistency in collection and then syndication afterwards?
Yeah, great. Thank you for that. That's an excellent question. It's actually Dr. Friedberg's organization and NCQA are collaborating on exactly that issue, how to improve race, ethnicity, language data. I'll just say from NCQA perspective, the other effort that is underway is advancing social needs screening and intervention measure, which will also present some opportunities around standardizing the collection of social needs or social determinants data, as well as, I think, race, ethnicity data. There's a strong need to standardize, and I think the FHIR enablement of the data infrastructure that allows this exchange and the other tools that people are using to collect the data can be will advance this and make it more consistent and more actionable. But I should turn it to Mark because he's done some really groundbreaking work in this area.
Yeah, it's a fantastic question, and we couldn't do anything on pay for equity or even our own external report without enough data on race and ethnicity. And Dr. Schneider's points about small sample sizes really complicated our reliability calculations for pay for equity, and we'll have a whole, we have like a 40-page methods appendix to our contract about how that's all done, and we'll have some publications about that. So stay tuned. Also, a presentation at the Academy Health Dissemination and Innovation Conference, I believe, in December. So that'll be a place where we'll be presenting some of that in more detail. We have a PhD biostatistician that does nothing but this for us right now, Gabby Silva, and she's written some great papers on this exact topic. Bottom line is there's nowhere it's very hard to start on this without having a substantial amount of gold standard data you've collected yourself directly. And so we've done that with our members over the past almost 2 years now. We have about 20% of our members have shared self-reported race and ethnicity data with us. That's more than enough to evaluate the accuracy of every other data source we receive, whether that's imputed data, vended data, which we don't use, by the way. Imputation outperforms every vendor we've tested. Provider source data, which varies by provider in terms of completeness and accuracy, as well as the data we get from accounts and data from state databases, which is not gold standard, by the way, that we found. And all of that kind of gets modeled together in a way that we can construct a payment incentive that accounts for measurement error. At the population level, it turns out imputed data work pretty well. So I'll give you an example. Statewide, we have an imputed black-white inequity in hypertension control of around 8.2 percentage points. And if we, that's on only the members who have given us gold standard data. So that's not a random sample, but that's what we get using gold standard data only. If we then pretend we don't have that gold standard data and use fully imputed data for that same exact population, that 8.2 percentage points turns out to be something closer to 7.8 percentage points. So it's not huge. It's not way off at the population level, and I would encourage folks to proceed with imputed data.
Thank you. Bruce?
Thank you all for your presentations. There's been considerable discussion within this committee in the context of integrating specialists into models and ACOs about nesting specialty care within a larger organization. Brian, your presentation to me, and I'm not a clinician, seemed to suggest that the choice between nesting and carve-outs is largely based on clinical criteria as opposed to others, economic or any others. So my questions for all of you, is that the right way to look at it, or are there opportunities for nesting, sorry, not nestling. Nestling is good too, but I meant to say nesting. Specialty care within larger organizations, and are they really constrained by clinical considerations, or are there more opportunities to accomplish that?
So this is Amol. I can start here. Now, I think it's important that we keep in mind, to some extent, what is the system of the future that we would like to build. And I think if we look at the models that have kind of served as the flagship models or the most representative models that provide great, cost-efficient population health management type care, they tend not to be models that are highly fragmented in that they're carved into a bunch of different episodes, that are carved into a bunch of different segments. They tend to be models where there is still a population health model that's kind of governing. There's a fixed budget to some extent and a direct incentive for providing high quality care within that budget. And then there are mechanisms to engage specialists more effectively in a variety of different ways. And we can talk about this in the context of integrated delivery systems like Geisinger, Intermountain, Kaiser, in the context of certain Medicare Advantage plans like CareMore and others that have demonstrated higher outcomes, if you will, from a patient perspective. And so I think we should be thoughtful and careful about the idea of creating a heavily carved out set of models. I think it could make sense as a transitional step, but we should be thinking in the long run that we're moving toward a model, and I think Liz Fowler and others have spoken about this, where the goal is to have a model where every beneficiary is aligned, or every patient is aligned to some sort of accountability-based model, and over time to a population-based model. And so I think we should be, again, thoughtful and careful about this, and I think that has implications, Bruce, for your question. Because I think if we're thinking about population health model constructs to some extent as the destination of where we're headed toward, then while it may make clinical sense to some extent, there is focused accountability. That doesn't mean that we want to fracture that or separate that, even if the clinical considerations might lead us in that direction relative to economic or geographic ones. We might, in fact, want to think about the economic, geographic, and other care patterns and community-based structures as ways to create cohesion where we otherwise may not have cohesion, purely viewing things from a claims data utilization-based clinical lens. And so I think we should be very careful and thoughtful about these mechanisms, and obviously certainly welcome Brian's thoughts as well here. Thanks.
Yeah, so I'll go back to the numbers I shared on participation and share another stat with you here. So of oncologists who qualified as an advanced APM participant in the Medicare program and received the AAPM bonus or will receive it in 2 years now, 70% of them did so because they were a part of an ACO. And I think it's great that they're a part of an ACO, but I think it's also a challenging question to say, are we getting the money's worth out of that? Are those ACOs making an investment through receipt of those AAPM bonuses on oncology care within oncology care? And if they're not, how do we see improvement in care and quality for the patients? And so if that is carving out, if that's really pressuring more within, participate in specialty care models that have the quality measurements and have the appropriate care redesign that we want to see, I think something needs to change, whether or not you nest new requirements within your ACO for patients of certain conditions, or you do carve-outs and make those requirements. One way or another, we really need our investments, whether they be the AAPM bonus or other incentives, to go to the patients who need it.
Thank you. I'm going to turn it next to Josh.
Great. Amol, Mark, Eric, and Brian, thank you for really thoughtful presentations. My question, I think, is probably directed primarily to Brian and Amol, but welcome, Mark and Eric, your thoughts to the extent it has implications for data gathering and capacity building. But, as we think about primary care and subspecialty care integration, two things surface for me. The first is that I think subspecialists have important roles, not just in procedures, but also in conditions. And so how can we think about, condition versus, condition versus episode-based, condition versus procedure-based episodes? And then the second is we talk about providers as, a group, but as we all know, it's not a monolithic group. And so as I think about how participants in these population-based models might interact with specialists, and whether it's nesting or carve-outs, how do we think about organization types? Hospitals versus physician groups or other types of organizations. So I wonder if you could comment on both of those kind of episodes aligned to conditions versus procedures, and then organization type and how that might affect how you think about integration.
Sure, I'll take the first one. The difficulty is when you talk about a given specialist, and if they are part of different organizations, so an independent practice group, it's very difficult to do it on condition-based because the patients flow to certain specialists at different times, right? And so not everything is go to the surgeon, go to the rad-onc, go to the med-onc, in that order. And so, I attempted to work with a large employer on this particular issue, and it was so difficult to try to do navigation at a specialist level that captured all those patient scenarios of where they go first. And so then you have to think about it proactively, whether you're an ACO or whether you're an employer wishing to do some type of navigation program, and try to catch patients upon diagnosis, or even sometimes that's too late in oncology, on prospective diagnosis after screening, and start them in their navigation process. Or else, patients get lost and they go outside your system and so on, and you don't know all the care that they're receiving.
So I can add a couple of points here. I think to some extent we in our work, and I think in CMS's contractor-based work as well, I think there's been a partitioning of the way we think about episodes as medical versus surgical, or condition versus procedural. And to some extent, I think that makes sense because patients with conditions like congestive heart failure, for example, tend to be a lot frailer and tend to be much sicker than patients who are going through elective orthopedic conditions. On the other hand, I think to some extent we're missing the most important point, which is the care in fact episodic or not? Or is it part of a cyclical chronic disease management type of profile? When we look at patients with congestive heart failure, guess what? It turns out that they're not just admitted for congestive heart failure a lot. They're admitted for pneumonia. They're admitted for COPD. They're admitted for heart attacks. They're admitted for sepsis. They're just admitted a lot, right? And so in fact, drawing lines in the sand to say this is a congestive heart failure episode versus a pneumonia episode is really hard for these patients. And I would contend, in fact, for a payer, it's essentially arbitrary because of the cyclicality of the way the care is happening. So I think to some extent, the way we're categorizing these is missing the most important. We're sort of missing the forest from the trees here a little bit. We should be instead looking very carefully at what the practice patterns are and saying what patterns truly have this episodic nature where you have a sort of baseline level of utilization and spending that truly spikes and then almost returns back to that baseline. That's a situation where, yes, it makes sense to really think about some sort of episodic model and specialty-oriented model, especially if that spike in utilization is heavily managed or concentrated within a particular specialty. So that means, by the way, that there will be some medical conditions, perhaps an acute myocardial infarction, just to throw it out there, is, and I don't know this empirically to be true, but I could speculate, maybe that's the type of condition, medical condition that fits an episodic model. And there might be other procedural conditions, some orthopedic conditions that require a lot more ongoing procedural care that might fit into a condition-based model, quote unquote, rather than into an episodic model. So I think we should be thinking about it from a practice pattern perspective rather than trying to artificially apply some sort of clinical construct onto it where it doesn't necessarily follow the right pattern. Your second question, which was around what about the organizational entity? And to some extent, I'm going to paraphrase your question, Josh, as does it matter, right? And I think, in fact, it matters a lot. And the reason it matters a lot is because the types of organizations and therefore their approaches to practice transformation and change management, if you will, differ. So if you have a hospital group, a hospital-based group that is accountable, they still have the four walls of the hospital, and a lot of the approaches are going to center around the hospital as the locus of activity. Whereas if you have an ambulatory-based physician multi-specialty group, their approach is going to be less facility-centric in some sense, and you're going to get different types of organizational investment. So I think we do need to think about that. That's one axis to really think about. I think the other dimension that we should be mindful of here is if we think about total cost of care accountability in the context of a population-based model, it takes a lot of lives. I think Mark has been talking about this in the context of quality measurement and reliability. It takes a lot of lives to get reliable measures and the ability to actually turn around and say, yes, we can decipher signal from noise. That also means organizationally, you need larger organizations that have bigger populations. And one of the benefits to some extent of thinking about engaging specialists in some sort of aligned or coordinated episodic-based approach or specialty-based approach is that because you're dealing with a spike in utilization perhaps, and therefore a lot of spending, we might be able to reduce that sample size, if you will, and then get a more targeted financial incentive and quality measurement approach that actually meets the reliability standards that Mark and his team at BCBS Massachusetts would feel comfortable with and say, you know what, this makes sense. And so I think there are some puts and takes there in terms of thinking about organizational type, as well as the implication for how we might actually translate an incentive down to get more focused care redesign where we might not be getting it fully today.
Thank you so much, Mark and Eric. I'm sure you have more to say, but we are actually at time. We want to thank you all very much for this very rich dialogue. It will be very informative to our discussion later this afternoon. Now we'll be taking a short break and we'll be returning at 10:50. Thank you all so much for joining us.
Thank you.
Produced by the U.S. Department of Health and Human Services.